Hi, good afternoon, everybody, and welcome. My name is Jen Elder. I am the director of the Homeless and Housing Resource Center. And we are so excited for all of you joining us today for our webinar, Naloxone in Public Housing, Success in St. Louis. We have been working with this St. Louis team, following their work for a few months now and are just so impressed. We've got a panel of 6 presenters today, just really excited to share with you the great innovative strategies that they have used. So with that, next slide. We'll start with just a quick disclaimer. The Homeless and Housing Resource Center is operated by Policy Research. We're funded by the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services. But the opinions and views expressed today are not necessarily those of SAMHSA or HHS. Next slide. We have arranged for American Sign Language interpretation, as we do with all of our events. And we are just expressing gratitude for McKenna and Pamela for joining us today. We also have live transcription from a human captioner. So we are also really appreciative for Rhonda joining us today. If you have any technical difficulties, feel free to reach out to us via email or via the Q&A feature. Next slide. So just a couple other housekeeping items from me, and then we'll turn it over to get started. We are so excited about the response. Today, we have over 3,100 people registered for today's webinar. Currently, we're joined by almost 1,000. So with that, rest assured, your participant lines are muted, and the chat today is disabled. But that said, we want to hear from you. We received over 500 questions in advance of this webinar. So the panelists have already reviewed those, and they're going to be prepared to answer those at the end of the session. But during the session, reach out to us using that Q&A feature. Submit your questions, submit your responses. If you are really identifying with something, reach out, let us know. I'll make sure all of the presenters receive your feedback. Alicia's dropped the link to the slides today. Well, this will be recorded and available on our website. At the very end, we'll have a very quick evaluation for you and a certificate of participation. So with that, I do see that we are joined by Admiral Levine. So with the next slide, I will introduce her for opening remarks for today. We're really honored to be joined by Admiral Levine. So Admiral Rachel L. Levine serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. And she's working to ensure health equity is front and center to build a stronger foundation for a healthier future, one in which all people and places in our nation can thrive. Admiral Levine's storied career, first as a pediatrician and adolescent medicine specialist in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. Please, Admiral Levine, welcome. Thank you so much.
Well, thank you very much for that introduction, and good afternoon. I am very pleased to welcome you all to this important convening. Today, I'm going to share a few thoughts about this critical public health issue that continues to take the lives of too many people across our country. The overdose epidemic has evolved to include increasingly lethal opioids, such as synthetic fentanyl compounds and other substances of abuse, such as methamphetamine, and even new classes of substances, such as xylazine, that hurt communities that are already reeling from this enduring epidemic. The epidemic's ability to change over time demands a flexible and collective response from all of us, and that is why partnering with public housing authorities, local health departments, federally qualified health centers, mental health and substance use providers, and community health workers is so critical. In my role as the Assistant Secretary for Health, I help lead the implementation of the Department of Health and Human Services overdose prevention strategy, which is addressing overdose deaths and opioid abuse throughout our country. The HHS strategy consists of 4 priority areas: primary prevention, harm reduction, evidence-based treatment, particularly including medication for opioid use disorder, and recovery support. Our strategy recognizes that the full continuum of integrated care and services is needed to help people prevent, treat, and recover from substance use disorders. It also emphasizes the department's commitment to help those communities that have been disproportionately harmed by this epidemic for far too long. Housing providers play an important role in the whole of society effort to save lives by ensuring that all public spaces have the life-saving overdose reversal medications on hand and people are prepared to use them. In June 2023, I facilitated a roundtable improving access to naloxone in public housing with HUD and SAMHSA to hear from partners in St. Louis about their challenges with getting naloxone in a public housing unit called Parkview Apartments, which was the site of a mass overdose in 2022. Prompted by this roundtable, the Department of Housing and Urban Development, HUD, released a frequently asked questions document in September of 2023, explicitly stating that residents cannot be terminated from assisted housing for being in possession of naloxone, sometimes called Narcan. Then in December, I, along with the White House Office of National Drug Control Policy, the HHS's Substance Abuse and Mental Health Services Administration, or SAMHSA, and the Department of Housing and Urban Development issued a joint letter to public health departments and healthcare systems to partner with housing providers, as well as community development organizations and other housing agencies to expand access to naloxone and other life-saving overdose reversal medications in the communities that they serve. Today, you will hear from some of the same partners that I met with at that roundtable back in June and how they are operationalizing this public health work right on the ground. In closing, despite the heavy toll it has exacted, the challenges of the last number of years, including the overdose epidemic, remind us of a fundamental truth, that we need each other, that our happiness and our very survival depend upon our connections to one another and to our community. And that spirit of community is what we need now more than ever, and we must call it upon it again. I believe we can and must build those connections and opportunities to realize health and well-being for all. And we can do this in a manner that enables us to truly support health equity and engagement, access, and outcomes, and build a society in which all people in all places thrive without exception. We can do better. We must do better. And with all of your help, will do better. So thank you very much. And I'm going to turn things back to you, Jen.
Great. Thank you so much. We truly support your leadership in this area, and we are just honored that you joined us today. Thank you, Admiral. So with that, we will get right to the St. Louis team. So next slide, I am just so honored to pass it over to Dr. Rachel Winograd, who's going to help introduce the panel of 6 and tell us the story of St. Louis. Rachel?
Hi, everyone. Thank you so much for having us. We're grateful to be here and to share this space with all of you. Next slide, please. So my name is Rachel. I am an associate professor here at the University of Missouri, St. Louis, and I work with esteemed colleagues who will be joining us throughout the rest of today's talk. We're going to do a tag team operation here. So we'll each introduce ourselves at the top of our sections just to get going. For those who cannot see me, I am a middle-aged white woman with short curly hair and a bold lip color, which I applied for this purpose. Next slide. Okay, so let's get into it. We need to talk about the context of St. Louis. Zooming in, we here in the Midwest in St. Louis, Missouri, we are at the center of the United States, and we struggle with many of the same things that a lot of other similar regions struggle with that are in a post-industrial, Rust Belt, depopulating arena. We have stark and growing racial inequities in drug-involved deaths. What you see here is that in St. Louis City, where our Black and white populations are relatively equal, we've lost nearly twice as many Black people as white people to drug overdose in recent years. And the local context is really important and highly relevant to what we're talking about today. On the left, you'll see a depiction of Delmar Boulevard. Delmar divides St. Louis into the north and the south, essentially, which can feel like two different universes, even though they're only blocks from each other. Locally, we refer to this as the Delmar Divide because that's what it is, honestly. It divides the rich and the poor, the resourced from the disinvested, the healthy from the sick, and the white from the Black. In this presentation, we'll refer to North St. Louis because that's how we use it here. People living north of Delmar have shorter life expectancies, lower property values, less access to healthy food, quality education, and critical services, and are predominantly Black and at high risk for overdose. Next slide. It's also important to give some historical context to this divide because, as many of our community partners made very clear and reminded us in the wake of the mass overdose event, which my colleagues will speak to, this disinvestment and segregation did not start yesterday or last year. Some hugely impactful points in our St. Louis history. If you look at the bottom panels, you'll see photos of Pruitt-Igoe, which was built in 1954 as one of first urban renewal housing projects for local Black residents. It ended up deteriorating due to poor maintenance and crime and neglect and inattention. Pruitt-Igoe remains vacant and dilapidated and represents the abandonment of and within among many of St. Louis's Black population. On the top left, you'll see some protests following or amidst the closure of Homer G. Phillips Hospital in 1979. That was the only public hospital for African Americans in St. Louis and also served as like a paramount training and teaching hospital for doctors and nurses around the world. It was closed and vacated prior to 1980, despite huge protests and community petitions. In the top right, you'll see views of our famous St. Louis Arch. If you come, you do have to go to the Arch, but what you might not realize is that these photos are taken really blocks from each other. But in one, you see depictions of wealth and a thriving metropolis. In one, you see boarded up windows and abandoned lots. Again, these are blocks from each other, but feel worlds apart. Next slide. So given this history, it's no surprise that the drug-involved death rate among Black men in St. Louis City specifically is nearly double that of the next highest group. We actually have some updated numbers to reflect here. We can get to that in the Q&A if helpful. But the next highest group should be white men in the city, or it is here, okay. In fact, Black men in St. Louis City, death rates among them for drug-involved deaths are nearly 15 times higher than the average rate of the U.S. population. So setting us up for today, they've given you a little bit of background context. We had these death numbers and we have community advocates and we have a current context where people are now caring nationally both about the overdose crisis and about racial equity more so than they have in the past. But in 2020, we did not have a specific group, a specific coalition, an entity that was a targeted, intentional effort focused precisely on this critical intersection, this intersection of drug use and overdose and systemic racism and disinvestment. We knew a lot of the what, but we didn't know the depths of the why. So that led us to develop the Center Initiative. Next slide. Our Center project was indeed born out of a genuine collaboration between us here at UMSL, the university and academic setting, with access to data and resources and funding and various policy change levers, and multiple community organizations and individual champions who've been at the forefront and on the ground day after day delivering services and hearing the stories of Black drug users whose lives have been getting lost and upended by these interconnected dangers of racism and a toxic drug supply and a lack of tools and information that can save and improve their lives and the lives of their families. So to tell you more about the Center Initiative and what happened next, I'm going to hand it off to my esteemed colleague, Dajay Bradshaw. Dajay, take it away.
Hello, everyone. My name is Dajay Bradshaw, and I am the Community Partnerships and Programming Specialist for the Center Initiative. As you can see on your screen here, CENTER stands for Community Engagement, Trauma, Equity, and Renewal to center people who use drugs. The goal of this initiative is to decrease overdoses and work to preserve the lives of Black people who use drugs, invest in their long-term well-being by changing the system, centering their voices so we can change the narrative of drug use from one that criminalizes to one that humanizes, promoting safe use and increasing service options by uplifting harm reduction principles and culturally specific care. We do this in a few ways: advocacy, like me and my colleagues are doing now, direct intervention, bi-directional education through learning from our research and community advisory board, and deepening relationships with a community that has been neglected by healthcare and academia. During this project in 2022, over the span of 36 hours, St. Louis experienced one of the deadliest mass overdoses to date in this city, all in one building, with a poison drug supply, a neglected and vulnerable group of people, and a public housing complex without any life-saving naloxone in sight. They are more than statistics. 11 overdoses resulted in losing the lives of at least 7 people. Although this may be shocking to you, I want to let you know that this is nothing new. Black people, Black men in particular, have been disproportionately affected by overdose in my city and many cities around this country. For this slide, I want to say that it is as terrifying as it is to see how many people are suffering from substance use disorder. It is especially terrifying to me to know that there are children, mothers, sisters, and brothers mourning the lives of their loved ones. Before we move on, please join me in a moment of silence to mourn with my city and these families. I want to introduce I wouldn't necessarily call her my colleague, but I'm privileged to be able to work with her for this project, Latasha Barnes, who is the interim director for St. Louis Housing Authority.
Thank you, Ms. Bradshaw-Glenn. Good afternoon. My name is Latasha Barnes, and I am the interim executive director at the St. Louis Housing Authority. For those who cannot see me, I am a Black woman with long wavy braids, and I'm wearing a black and white striped shirt. To fully understand the story we're about to explain to you, we must first consider the historical context of housing policy in the United States. Before 1980s, housing authorities had limited ability to address drug activity on their properties. Evictions were based on traditional lease violations like failure to pay rent, breach of family obligations, and things of that nature. The war on drugs completely changed the legal landscape. The Anti-Drug Abuse Act of 1988 marked a turning point for housing authorities, giving them the ability to begin considering drug-related activities in their admissions and lease termination process, even making these offenses as an immediate basis for eviction under one-strike policies. The Cranston-Gonzalez Act provided funding for anti-drug initiatives like security enhancements, tenant education, and partnerships with law enforcement. It also created even stricter eviction rules. Finally, the HOPE Act of 1996 mandated more strenuous drug-free housing requirements, with each law gradually reinforcing this idea that exclusion, enforcement, and law and order were the only acceptable way for a housing authority to respond to drug-related activity. Public housing policy shifted from providing affordable housing as a sole goal to focusing on eradicating drug use, even at the expense of other objectives. This environment created a chilling effect on alternative approaches that would support more robust and trauma-informed interventions. To talk more about that initiative, I will now turn the presentation over to my colleagues and my partners at Center. Next slide, please.
Thank you, Latasha. I want to dive into what happened after that terrible mass overdose in Parkview. So immediately following, my team is ready for action with the large supply of naloxone and harm reduction training that we have here at the addiction science team. We are ready to provide education and distribute naloxone, not just in Parkview apartments, but in many others. Unfortunately, as many of you are aware, stigma for drug use and people who use drugs is very strong. And we were unsuccessful with our phone calls, emails, and showing up on site. To commemorate the event after a year had passed, all of the partners at team, we came together and worked to draft this public statement with our community advisory board, which is filled with people with lived experience calling for some sort of action to be done. We shared it on social media, through our community networks, over email, via voice. I mean, there was not a person that knew me or knew anyone at MIMH or knew anyone who was doing harm reduction work in St. Louis who didn't receive this public statement. Thankfully, at this time, when we reached out, we reached the ears of Alana Green, then director of St. Louis Housing Authority, who is they own the property. They connected us with the property management, and before we were able to arrive on site, we needed to address stigma with property management and staff. I'm going to pass it over to Pastor Pam. She is a harm reduction consultant here on the addiction science team at UMSL and MIMH, and she is going to talk with you about that initial training and the importance of addressing stigma through harm reduction.
This opportunity to share. We're grateful about the opportunity to share these things. They are very important. And the more that I hear about them, even if I've heard it 1,000 times, and I have, every time it moves me to work. I say, what more can I do, right? And so with this Parkview, mass death, that's the way that I see it. With that, a lot of people were affected, and immediately when we got the information, we wanted to get involved and see what can we do to make a difference. When I think of Parkview, there's an older gentleman that I grew up 2 doors down from. He and his family owned a business. When he retired, he moved to Parkview. So that was my view of Parkview prior to what happened on that day, right? And so my end of participation is to come in and help and deal with the stigma, right? And to train people about some life-saving tools that will make a difference in people's lives who use drugs, right? And this is what I did. When coming in and speaking with the people, there's stigma that is associated. So people would think that they would be arrested, right? People thought about being evicted. People thought about, could they be contaminated? And these aren't just questions that people in Parkview will have. These are questions that people have predominantly anywhere that you go. People were worried about, doing harm with some of the life-saving tools. And so my job was to come in and explain to them that none of those things should be associated with saving a life. Here in Missouri, we have a standing naloxone or order. So in other words, you can save a life. It has worked its way all the way down to regular people that you can step in and save a life. What you're seeing pictures of here is the naloxone, the Narcan, same thing. And what it does, you're also seeing fentanyl test strips there. Something that's very important, because what we find is the reason why people are expiring at this rate is because of the things that are mixed into the drugs, right? And so what they have here with the naloxone, a person can simply take the naloxone. If they suspect that somebody's overdosing, I always say, go with it. You can't be wrong. This is as harmless as water. A baby could literally drink it and still live. It only works if a person has an opioid in their body, right? So if the opioid is there, it's going to work. If the opioid is not there, there is no cause and effect there. The person will be just fine. And I do like to take at least the 30 seconds to describe how to do it because I'm certain that everybody has not experienced that before. And so what you would do if you had a box like that, you would open it up, and we want those boxes to be ready, available to people everywhere, right? You would open it up, you would snatch out the two injectors, I would call them. And what you would do is you would rip it out of that package. You go straight to that person. If you could lay them down on the ground, lay them down on the ground. If you could elevate their head a little bit, elevate their head a little bit. But one thing I know, this stuff works, period. We have many results of it and reports, and it does what it's supposed to do. So you're going to take the naloxone and you're going to put it into someone's nose. It's not a needle. This kind is you just ingest it. It comes in by breathing. So you're going to slide it up their nose, give it a squirt, boom. You're going to give them 2 to 3 minutes to come back. And in that 2 to 3 minutes, you're going to call 911 and let them know that you have someone that is non-responsive. And unfortunate to say, we need to say non-responsive because EMS is overworked. And so we want to express as a person, they're not responding, we need you quickly. So we just want to state it in that manner. Give them the 2 to 3 minutes to come back. In that time, hey, we even supply people with coverings. If you want to do a rescue breath, it's fine. It helps. Do a rescue breath, right? And you're looking for the results. Give them rescue breath. You don't have to touch them in any other way, right? You're waiting 2 to 3 minutes. You've called for emergency help. You have another dose in that box. Go right back into it, right? With the squirt in the nose, boom. And what it's going to do is the membranes here are going to take it up, and it's going to take it up to those receptors, and it's going to land on the receptors, and it's going to kick out the opioid. That's everything. And it's as simple as that. You've just saved a life. The green pack that you're looking at, we talked about that. We gave those out. And that is how a person could identify if there's something more than what they thought was in there. And it's unfortunate. Often people say, what is this? What are we doing? We are helping people and we are saving lives. The stigma that we hold and we think that this is attached to one group versus another group. It is very hard on African Americans, period. Why? There are a lot of situations that we have that would allow us to be in a place where we're not at our best and where we're looking for an alternate way to come up out of that. I talked to a young person this morning and he told me he's 20 years old. And he said, you know what? I want to get myself together, but I'm thinking, what's the use? My life is so terrible. Right. And so I went on and spoke with him and told him how wonderful his life is just to breathe. Right. And we talked, and hopefully he's going to take that advice. But with Parkview, it was very, very special because all of these people expired at one time and nobody was expecting that. All of this began to happen back to back. And so it made it more intense. Right. And so as we delved into the stigma of it and everything that's happening with the situation, we began to cut back on the stigma and let them know the truth versus the things that kind of stigmatize us from getting out there and being helpful. That no, you're not going to kill anyone. No, you're not going to get poisoned yourself. No, you're not going to be arrested. And once people knew that, it kind of relaxed them a little bit and they were prepared to hear what else we deal with as it pertains to overdose. And when you think about who's all involved in it, African Americans are number one, the men and the women. but everybody is important when it comes to this, right? And so what I would say is the best thing we can do is what we're doing now, educate ourselves so that we'll know what to do, when to do, and how to do it. It was also important to me, Parkview. One of my classmates died in Parkview. And all I know is the last time I saw him, everybody was shouting his name, right? Because he was very popular, he was very loved, but it didn't change the fact that he died in the situation at Parkview. So one of the big things that I would have as a takeaway from this is that everybody is able to help, whatever level, whatever degree of help that we want to put out there. You're welcome to do it. People are waiting on you to do it. And it is safe to save lives, period. And with that, I will introduce Dee Anthony and Hannah.
So, hey, everybody. I'm DeAnthony Henderson. I'm a community health worker at Family Care Health Centers. I'm a Black male, Black young male, and I'm wearing a black shirt that says Black Babies Matter. Part of our process of providing harm reduction is to combine overdose education and naloxone distribution and assess for social determinants of health. We work closely with a lot of external partners like the T, ALMSU, MIMH, who provide a large amount of naloxone and other harm reduction supplies, while our organization, Family Care Health Center, helps us provide services and resources that can help individuals within the community. Being on site and having naloxone on hand helps lower barriers to accessibility. Our outreach started small, but we are currently at 12 different sites, including public housing locations and encampments of unhoused communities. At CHWs, we provide a variety of harm reduction materials like wound care kits and condoms, as well as provide blood pressure screenings and diabetic education. We also help connect residents to treatment options like methadone clinics, respite housing, sober centers, and transition housing, connecting residents to different primary care clinics and other healthcare resources can help eliminate some of the barriers they may be facing. Part of our job as CHWs is to assess the social determinants of health. When we are communicating with the residents, we're able to return with the resources that help them meet their basic needs. Coming with resources in hand like food pantry locations, transportation resources, and things that help assist with Medicaid actually helps increase the residents' accessibility to resources. The effectiveness of relationship building with other health resources and community organizations like the T, Mo Network, and ARCA helps us bridge the gap between the residents and the care that they want. Continuously building a rapport with the residents allows us to have valuable conversations that leads us to the specific needs they have versus what we think they need. So when we got to Parkview, we actually set up a table and, asked residents what they needed. And one main thing they needed was government phones. I mean, a lot of people don't think that, government phones is a barrier, but it is. So we had a government phone organization that came out and actually helped about 45 residents with government phones and tablets. We're also working on bringing in home health care organizations and nutritional services that have been requested by the residents as well. Next slide.
Hello, everybody. My name is Hannah Oberg, and I'm community health worker, housing specialist at Family Care. And for those that can't see me, I'm a young white female with straight blonde hair. So for this model of outreach to be successful, it takes many moving parts and key players. Like the start of any good project, a strong foundation is needed, and in this case, community health workers are that foundation. CHWs, per the American Public Health Association's definition, are trusted members and have a close understanding of the community they're serving. This trust allows them to serve as a link between community members and resources, which makes them vital to the outreach's success. With the unique role of community health workers, we can communicate and collaborate with organizations like local housing authorities and property management companies to start relationship building. The relationship building piece can take some time and can be challenging, but once established, it can open the doors to new possibilities to assist communities. After developing these relationships, the next piece of the project is to start the work. The overdose education and naloxone distribution training for the Housing Authority management and staff here in St. Louis was made possible by the addiction science team at UMSL, who continue to provide a large supply of the naloxone. With the help of the Housing Authority, we came in and extended the OEND training to the residents and community members. After some time providing the training and resources to residents, the Housing Authority bought into the model that we were trying to implement. This buy-in has led to our outreach team of community health workers getting into spaces within Housing Authority properties and having a dedicated community health room. As D'Anthony discussed earlier, we were able to provide medical education within the limits of our scope of practice and other health resources to the residents to secure the 4 S's: security, stability, safety, and survival, which will be explained next by Dajay. Next slide.
Hello again. I realize now that I did not describe myself, so I'll go ahead and do that now. I am a young Black woman with curly hair, for those who cannot see me. But anyways, thank you so much, Anthony and Hannah, for providing a closer look at the work that you guys have been doing consistently over the last year. I want to kind of take a step back and talk about the Center Black Advocates Research Study, which is key in the collaborative model for outreach and access. This study, we completed 2 focus groups with Black people who were peers, volunteers, CHWs, who are doing the work, doing the outreach, and volunteering to connect with Black people who use drugs. We wanted to deep dive into understanding why the rates of fatal overdoses are increasing amongst Black men in St. Louis. What we found, what our participants say, is that Black people most at risk of overdose do not have the needed social determinants of health, like nutritious food, clean air, stable housing, and social support. The lack of security, stability, safety, and survival, it creates very real barriers to accessing services. It creates additional needs for patients to be successful once they're in services. And it also creates a higher risk for negative health consequences and even death. When someone is in crisis every day for a majority of their lives, struggling just to get by, they don't often have the external and internal resources to be successful with something as hard as lessening their chaotic substance use or being successful in treatment. This is core and is one of the drivers as to why Black people are dying at such a disproportionate rate. Before I get to the next slide, I kind of want to brief you a little bit. This is the simplified version of a full diagram that will be provided to you at the end of this webinar. But for today's talk, I want to focus on the part of this diagram that came out of the Center Black Advocates study that gives us a direction on how to lower those barriers and deepen trust. Trusted community members like D'Anthony and Hannah and other community health workers, people who look like you, understand you, who don't judge you, cultural strategies for resilience, like bringing pride in your identity as a Black person, leaning on religious and spiritual practices, and one of the major key pieces like harm reduction information and tools so that people have what they need and the know-how to keep themselves safe is key, like pivotal in bridging the gap that we see that is causing opioid overdose deaths in my community for people who look like me. I want to kind of end my section with this quote at the lower left corner of your screen that says, "That's what I love about and in quotations being a CHW. We are the people from the neighborhood who have gone. We look like them. We've experienced the things that they've experienced, and we see the value in the hood. I'm going to go ahead and pass it over to my colleague, I believe, Pastor Pam. Oh, sorry, just kidding. Actually, I'm going to play a video clip of resident testimony that talks about their experiences and the impact of this on their lives.
Why do you think there's still a stigma? You know what stigma is?
Yeah, I know exactly what a stigma is.
Why do you think there's still a stigma and some pushbacks for residents to help other residents who might have substance use disorder?
Well, everybody still look at it like it's the worst thing in the world, which is not a good thing, but it's a sickness. So if we look at all the sickness as sickness, we can combat it the same way. And people, that's what they're scared of. You know, they always put it, a war on drugs, is how they always put it. So what you think it war? Violence. You equate violence with war. That's the problem. But there's actually, you can help. It's better helping them to get away from it, because if you do that, then what person you think gonna break in your house to help them, you fed them last night, or help them get off drugs, or help them do anything positive? They gonna ask, you notice like how around here they treat me a whole lot better because I help everybody instead of, and you can see the same people just like me, but they don't treat them nowhere near the same because they think of them as the drug addict.
Yeah, and I kind of like, how is it when you talking to somebody, say for instance, you trying to help somebody learn about Narcan,
right?
And they be like, oh man, I don't want to deal with this stuff. How do you feel?
It breaks my heart actually, but once they figure out that everybody got one in their family, it's not, see, this sickness ain't like a cold, you can just see it off the bat and you can take some. This is the only thing that tricks you, to tell you that it's not there anymore, and you'll forever be like that. But I've actually got a lot of good feedback since you guys been coming through and helping us. Like I've saved numerous lives because of the Narcan, and people actually come to me now and ask, like, hey, you got some more of that stuff you showed me how to use? And then we wouldn't be no good without y'all. Right now, we need so much more. I mean, we're appreciative of what we got, but it could be so much more done, man. And we really need it. And it's, at this point, like I can see in a lot of people's eyes that they tired of not having the resources. That causes frustration. So, man, it's in dire need. We need it, and we appreciate what we do got, but we can always use a little more.
So, what resources would you like to see more of that would be beneficial for you or the community?
Well, more outreach, like what you do. You come out and you actually help us get the things we need and supplies with it. And it's not going, if it was going to waste, I can understand why they wouldn't want to, but it's actually helping and it's combating it, because I know for a fact in this neighborhood alone, 30% less crime. Now, I ain't gonna say it's less gun violence, but it's less burglaries and stealing and theft. And more so, the community is trying to heal itself, but we do need the help.
What have you been able to take away from this type of work that we've been doing?
Well, the things I've been taking away is actually keeping me and the majority of my community around here alive. We only lost one since you guys been coming. Thank you. And prior to that, we lost 4 in a row.
Okay.
So it's definitely helping, and we're appreciative of it.
So in the past, was it more than that, or how?
Yeah, hell yeah, it was high. It was going. It kept going up because we had no resources, and y'all popped up out the blue as like a godsend.
What type of impact do you think this type of work has had on either you or the community?
It's actually had so much of a positive impact on us, because at first where we had kids out here wanting to be on these corners, as you can see, we done cleared. As you can see, they clear now. Like, these kids are actually going to classes, going up to the recreation center. They not worried about their mama being out here passed out no more, drunk or high off drugs or anything, whatever they was doing. So it's actually been so much help for us.
Okay, that's good. Now, I appreciate it too, because, I mean, You don't have to do that. You don't have to like help people and all that.
Yeah.
Care about your community.
Enough to notice that when we get some, because I was for a second when she had the die down coming, we were scared I was gonna stop coming, and because I was starting to see more and more of the same things, the same repetition shit, stuff before you came.
Oh yeah,
You know, so but it's back down because they see, okay, so they are gonna be here on for the long haul. Because at first that was the conversation, like, yo, they just coming through it because they got to.
Yeah.
But now we see actually doing it for Kurt. We gonna help us if y'all help us.
And that's the thing. That's what we're trying to do. We're trying to, be consistent. And if we ain't trying to be that, those community health workers that come through and be like,
Card to be gone. Y'all stay with us, and we appreciate that, man.
I'll stay for a couple hours, talk to y'all, chill, and
You have a young lady that come with you on the regular. She good too. Like, and that really touched our heart. Like, cause we don't really have white people come down here and help us. We really don't. Like, they'll come through in a bundle and, we'll be here there. And we never see them again, but we see y'all consistently. So as you can see, we consistently try to make sure things stay straight. We're not going to hurt none that ain't trying to hurt us. So we try to make sure y'all's good. We keep all the bull stuff around, flow and smooth. And y'all help us with that a hell of a lot, man. Y'all just don't know how much y'all combat the bull stuff. The guys that used to be sitting right there on the corner with their cars, sitting right there selling their stuff, don't even come around no more. So we do appreciate y'all for that.
I appreciate you, bro.
And I'll take us back to our presentation. And for these next few slides, we'll have D'Anthony and Hannah taking it away.
Okay. So taking an alternative approach to treatment for people who use drugs, our clinic developed the role of CHW substance use specialists, which was primarily funded by the Center Project. Because CHWs come from diverse backgrounds, various lived experiences, and specialties, being intentional about who is added to the outreach efforts is critical. When our outreach work started, D'Anthony was our sole CHW who was dedicated and collaborated with our external partners to make connections with people who use drugs. Our outreach team now includes 3 additional community health workers to help in our efforts to reach all community members with or without drug use.
While increasing our capacity to include more CHWs in the community, we also have to keep in mind that being consistent is key. Having a set schedule with the community members allows them to keep faith and know that, there are actually organizations out there that care. So, like the example that the resident gave us, one time we went to a conference and we had to miss a week, and we came back and he was just basically saying, like, due to past experiences, organizations showing up and handing out things, and they'll never come back. So he thought that we were never coming back. Reasons like that, are why it is important to keep it real with the individuals you work with and consistent with the schedule, so that we aren't creating more mistrust and disconnect between the community and public health. While we are on our reach engaging with the communities, we are mindful of the language that we are using. Not saying things like addict or substance abuser, instead using safe language like person with substance use disorder or unhealthy use. Changing the language we use helps individuals view themselves more valuable than how most people look at them and how society has labeled them.
So all of the things that we have done and have talked about have helped us build meaningful relationships with the residents and other community members. These relationships encourage the continued practice of healthy conversations because we have earned their trust and they know that we can help them to whatever path they may be on in their journey. Next slide for Latasha, please.
As you've heard throughout the course of today's discussion, there are a number of challenges, right, that may impact your ability to advance this type of collective effort, especially if you're looking for the type of transformational impact described in today's testimony. You have to meet people where they are, and place-based initiatives are the best way to do that. And if we're talking public housing developments, you cannot do that without close collaboration with your local housing authority. It's critical and essential. This work cannot be done without their buy-in and their support. And that does not exist without first building a genuine relationship with key leadership and understanding some of the concerns they may have regarding partnering. Fear being a foremost factor, including the fear in acknowledging that some people do misuse substances, and the fear that the presence of certain harm reduction tools may unintentionally encourage that behavior, the fear that it may result in increased drug use, the fear that it may attract negative attention or a negative reputation for that particular community, none of which have to be true, but these fears are very real and they're very present. Even though substance misuse may be the result of complex trauma, negative coping mechanisms, or adverse life experiences, there is still a lot of fear and stigma around addiction. Community members will not be open to accepting resources from you, especially if they are fearful of how their housing managers will respond. And so making sure that you have a housing partner who is willing to be very open and supportive of the collaboration and to communicate directly with the residents around these topics is critical. Some housing authorities and management companies may be concerned about the potential exploitation of low-income families. Just as Mr. DeAnthony mentioned, inconsistent collaboration creates increased distress for our community members, and that is not the type of partnership many of us look for. Some housing authorities and management companies may be concerned about the potential for liability, especially in light of the laws that require us to take certain enforcement activities. But what we found here at the St. Louis Housing Authority is that in an emergency, and the opioid crisis is a public health emergency, we must try to prioritize the preservation of life when we can to the best of our abilities. This requires a shift in perspective. This requires a leadership buy-in. This requires focusing solely on resident well-being and carefully considering how fair housing protections may actually come into play. The good news for us moving forward is that public policy is not static. It's evolving. It's evolving every day. With recent support from the White House, with recent support from HUD, with recent support from HHS, SAMHSA, and other esteemed regional leaders, it is much easier to collaborate around these issues. At St. Louis Housing Authority, we are especially thankful to our federal partners for their leadership on this topic. Their official notices and guidance documents and FAQs help us move this effort forward in ways that we could not imagine. Now, more housing authorities across the nation are exploring comprehensive approaches to substance misuse. They're incorporating social services, and they're increasing treatment options in their housing development, which is good news for the communities that we serve. And I will now turn it back over to Dr. Winograd. Next slide, please.
Okay, so as we're prepping to wrap up our section of this webinar and open it up for Q&A, I just want to pause and make sure we're all following along as we've sort of been pinballing this presentation. The reason that we've done this pass the baton strategy is because no single one of us could have done this presentation alone, because no single one of us could have, carried out this effort alone. So when HHS asked us to do this webinar, because they want to scale up this type of model across the country, we're like, okay, cool, but we need to be really clear about all the components that are necessary if you want to replicate this in your city or your region. So just to make sure that we're all even on the same page, we've listed out really simply the key ingredients that made this possible. And without one of these, it wouldn't work. So first is you need access to a big naloxone supply. And we could get into the weeds of that. Yes, a ton of federal money and opioid settlement dollars have become available in recent years to buy naloxone and launch all sorts of initiatives and buy products, but it's still not enough for a lot of entities. So make sure before you launch this, you know where you're getting your naloxone, and it's going to be a steady supply. It cannot just be a one-time thing, obviously, because people are going to use it. You want them to, and that you're going to need more. The second ingredient is the training for property managers. As Pastor Pam alluded to, earlier, we had to get in there and get buy-in to train the staff and the people who are running these properties before they let DeAnthony and Hannah and team come in and play the ground game. Without educating them first and getting them to sign off and getting their buy-in, none of the subsequent actions would have been effective or even possible. And then third, those folks who do the ground game, as you've heard in the videos, you've heard directly from DeAnthony and Hannah, that personal door-to-door relationship building and human connection is the secret sauce of all of this. It's one thing to do a mass naloxone drop-off or some big Zoom training. It's another thing entirely to be showing up week after week, knocking on doors, shaking hands, giving hugs, knowing names, and making real connections with human beings. And then the fourth and last thing is, yes, it's great to go with naloxone and even resources to access substance use treatment, but people really quickly started asking for a lot more than that. So being able to connect people to other resources, DeAnthony and team, they sign people up for Medicaid. They get them connected to primary care providers. They help connect them to get, tested for all sorts of infections or STIs, get vaccines. I'm sure there's a ton of other resources that they provide on a given day when they're out there that I don't even know about to mention right now. So making sure that you have the big picture at play here. Yes, this primarily started with naloxone, and that really has been what has gotten our foot in the door. But it's about so much more than that. And that, as you heard from the gentleman in the video, they're really grateful for the resources that they get, and they still need a lot more. So ideally, you'd be connected to a much bigger network of resources who can pop in and serve people in need once they have the naloxone and overdose education in hand. All right, next slide. I'm going to hand it to Triple P Threat, Pastor Pamela Paul, to close us out with some takeaways.
I tell you, we're getting right into the thick of it. So here are the key takeaways. It would be the public housing environments are a key sector where there is a need for naloxone. So now that we know a little bit more about it and a little of that stigma is gone and we can continue to learn more, we know it's definitely key. I'm looking here at getting into public housing takes relationship building and trial and error. So sometimes maybe it didn't go the first time, the second, or the third, the way we wanted it to. But we need to be committed. We need to be able to connect people with other resources. Naloxone isn't enough on its own. And as I end with thinking about the key takeaway, right? So I'm a harm reduction specialist, right? And I work out of the addiction science department. But with that, I think about what we said, the commitment and knowledgeable. We can remove those stigmas and it would allow us to be able to see people the way we want to be seen, right? I would say that everyone is definitely susceptible to this. And I can prove it. I can tell you that I have an uncle, Richard. He died of an overdose. I could tell you that I have two cousins that died of an overdose, Carrie and Ronald. Carrie was a stay-at-home mom and an amazing one. Ronald was a barber. I could tell you that I have a nephew, Trey, that died of an overdose. Trey was a singer and a great one. And I could tell you that my big brother, Corey, died of an overdose, and he was a delivery driver. And I can tell you that my oldest son, Brian, he died of an overdose, and he was a store manager. None of these people were somewhere just twiddling their thumbs, but they were living their lives, and they happened to succumb to a substance use disorder. So what would I say? We are making a difference, and we can keep pushing and making a difference. Small scale, large scale, it is still making a difference. I would pass this on, and now we have time for our questions and answer segment.
Thank you so much. What fantastic information. So now at this point, I'll invite the whole panel of presenters to join. We can take the slides down just so we can see everybody easiest. And we received some questions beforehand, so I will pass it back over to your team to go through those and also encourage the audience. We've been getting really good questions throughout this, really great comments. Keep those coming. Got about half hour together to share. So I'll pass it back to Rachel.
Gotcha. Okay. We were so worried about prepping for the talk part that we're like, okay, we're done. Oh, wait, no. We're doing this Q&A session. We got this, team. We got this. Okay, I'll kick it off since I awkwardly inserted myself here. And I was noting and answering some questions in the Q&A box as we were going and saying we should come back to some of this stuff. So let me just kick off with that. There were some questions in the chat related to sort of proper overdose response. So let's take a moment to clarify what that is and address some misinformation that's out there. So first thing first is we really do want you to leave this webinar knowing the importance of rescue breathing in addition to naloxone administration. So remember that an opioid overdose, what it is respiratory depression, meaning your lungs stop talking to your brain and you're not breathing. So the most important thing you should do is get oxygen in someone's system. And the best way to do that is to breathe for them. That means you're lying them down, you're tilting their head back, and you're doing mouth to mouth. That's why we give breathing masks in our naloxone kits so that people can feel comfortable putting their mouth on strangers. Even if you don't have naloxone, you can absolutely still save someone's life if you breathe for them. So definitely do that. Give the naloxone and breathe for them. Wait a couple minutes. If they're not coming back, you can give more, but keep breathing for them. So back to the naloxone dosing question too. We had a question about higher dose naloxone products. We've been hearing a lot more about those products in recent months. There's a heavy marketing campaign. What I want to address right now, and just state clearly for the record, is that standard naloxone works just fine. In fact, I recently returned from an international summit about naloxone dosing, and we had researchers and people with lived experience and experts from around the world who we put all our data together, all our heads together, all our stories and anecdotes together, and everyone was on the same page that even over the last 5-10 years, as fentanyl has been taking off, we have not needed more naloxone to reverse those overdoses. Often people understandably get really nervous and panic in the moment, and so they might deliver multiple doses of naloxone. That doesn't mean that you needed that many. You likely could have revived them with 1 or 2. So that's the most average response, is 1 or 2 doses. The thing about that too, there is a danger in giving too much naloxone to someone who is like physically dependent and has an opioid use disorder. So this, I'm not trying to complicate this more than it needs to be, but if you do what's called stacking naloxone, just like giving dose after dose after dose, someone can go into really horrific withdrawals, meaning they're really dope sick. They're violently vomiting, diarrhea, shakes, chills, anxiety, insomnia, horrific pain. And that's a problem in and of itself. Sure, they're alive and that's good, but all that harm could have been avoided if you slowed down, administered 1 or 2 doses, and focused on the breathing. The last thing I want to address is, while we have featured the nasal Narcan product in our images and trainings today, we absolutely should also be talking about the intramuscular injection variety, which comes with a vial and syringe. This has been the tried and true method for decades and decades. And it's how you use it is you draw up, you take the cap off the syringe, you put it in the vial, you pull up the naloxone, and then you stick it into any big muscle, a big shoulder muscle or a thigh, and you inject it swiftly. Now, that is also incredibly effective. Again, a tried and true method. And because it comes at a slightly lower dose, it is less likely to lead to those horrific withdrawal symptoms, which is one of the reasons that a lot of people who use drugs actually tend to prefer the intramuscular variety. So just wanted to get that out there for the record about proper overdose response, because I noted there were a number of questions in the Q&A. Happy to speak more about that if helpful. But how about now we move on to another question, and one of my colleagues can speak to it. So who's up? Who's going? I know you've been looking at the questions while I'm talking. Anthony and Hannah, there we go. Okay.
I was going to say, I just saw one really quick that popped up that asked, do the CHWs have access to their continuum of care to enter people into a coordinated entry system, or do they have each entity go out to the community? So Family Care actually just recently joined the St. Louis City Continuum of Care as the first FQHC in the city to be part of it. And so we have that as a resource. We're still figuring out how we can work them together and how, we can refer the people that we're working with and that we're meeting out in the community, how we can refer them to these other organizations that are in the COC. So
I do see a question in the chat regarding whether to approach the individual property managers or the entire housing authority when trying to set up an initiative. And so my advice would be to start with leadership at your central office, build those relationships there, and they will help you establish the relationships you need with the property managers on site so that you can have a more successful experience.
Okay, I'm going to call us out. This is my job and I'm familiar with it. Okay, Pastor Pam, you're up. We got a question for you. Someone said, I have a question for Pastor Pamela Paul. How do you overcome the stigma of substance use and discussing saving methods within the faith community?
That is a great question. And that you would think.
Uh-oh, you got muted somehow. There we go. Okay. Sorry about that. I said that is a great question. And you would think that that would be the easiest community to be able to get into, since for the most part, they're all about helping. However, what I do is I keep humanity before them and keep reminding them about their role in the community, to be a humanitarian and help that community. And it would be just the same if you saw, people's property deteriorating or their access to the bus stop and this and that. As a faith-based community, you would look into it and say, hey, how can we help these people? So when you look around, I tell them that when they look around their community and see what's happening in their community, then that is the thing that they should be working on. And that is the thing that they should be helping with. And I remind them that one of their major roles in the faith-based community is not to judge, It's not to judge. We're not the judges, but we should be people that are helping others and giving them a leg up. So I remind them about that and the stigma, just give them the real data and let them know, these things aren't true. And over time, they do accept it. And generally, and I hate to say it, but it takes someone in the church sometimes to die for them to understand how real it is. I've had people, and I'll end right there, that said, hey, no, we can't do it. I don't want anybody to come in. I'll talk with them and I'll say, okay. And then quickly they'll call back. It won't be long. They'll call back and someone will have perished. And so if they're in the business of saving lives, then they get engaged. Thank you. Okay. I see Latasha is typing an answer to Caitlin Krause, but I would love for us to answer this live and hear from both Latasha and D'Anthony and Hannah. This one says, hello, I'm a community health worker at Teros Health in Arizona. We do a lot of Narcan trainings. This week, we've been training at a low-income apartment complex. It's hard to get people to show up. I'm not disheartened because I still believe in showing up and always being available for when people do decide to attend. But what are the best ways to get people to care? What are the most effective ways to advertise?
If it's okay with D'Anthony and I'd like to start. I do want to say people do care. We may not always see it because of trust issues, because of ongoing traumas they may be facing. Some people are in a constant state of survival, and it's really hard for them to lean into these types of ideas. But persistence is important, and I can say our partners at Family Care Health Centers have been very persistent in building trust with our residents and showing up on a consistent basis. I would recommend working directly with the management to partner on existing events, showing up when they are having other meetings and other resident events, creating that increased visibility, making sure that they know who you are and that you are truly invested in what's happening in their lives and in their communities. I would also agree with the statement D'Anthony made earlier about just giving it some patience, right? Sticking to it and knowing that eventually people will start to lean in.
I could weigh in a little bit. Our first initial stops at Parkview, I mean, it was kind of slow, but we've been there for some time now, and we actually see about 15 to 20 people a day. With the help of Latasha and Alana and our management, we've been able to put around flyers and stuff like that, which has helped us get the word out. We even stand outside the community room to even catch people walking in and out. We usually just set up around places that are like high in traffic. Have anything to add?
I would say, I think the other thing too to get people to care, even though like Latasha said, people do care, is to really find what makes them interested, and that's part of that relationship building. Figuring out what are things that they want or need as far as their needs, and then trying to bring that in. And then adding, the Naloxone training to it. And so they're getting their needs met. You're able to provide the training that can then help save someone's life in the future. So I would say it also just comes down to good relationship building.
Yeah. And another thing that helps us is having things on hand, something that we can just give to them so we can engage into a conversation. Because, when people see, Narcan on the table, they don't want to talk about it. But, if we got something that we can give you, maybe we can make you more comfortable with talking to us.
And I think too, with just like having the Narcan on the table, we actually got like dummy noses. And so we set those out on the table, and that draws a lot of people in too. They're like, why is there just a random nose on the table? And you're like, well, here's why. And now I'm going to show you how to use naloxone. And then, here, show me how you use it, and do like that teach back and get them interacting with you as well.
I just want to toot their horns a little bit more, because I don't know if we made this super clear during the presentation, but a couple months ago, through D'Anthony and Hannah's advocacy within Parkview Apartments, they now have their own room in the complex that's dedicated to them. You guys, it's yours on every Thursday, right? You share it other days of the week. It's now like a community health room. So they post up in there every Thursday, and people know where to find them. And that's kind of what we were hoping for. Like when Admiral Levine came in the summer and we did a roundtable that she was talking about, we were saying, like, what would we want next? We'd want something in-house. Ideally one day it would be a full-fledged, clinic or drop-in center or something that's really co-located where people could get full spectrum services on site. But in the meantime, them having their own room where they can have access to these resources, keep these supplies, and people know they're there, is, I think, is super powerful and addresses the original question about like, how do you advertise? And like, it's kind of about longevity and consistency. And then the slow and steady trickle will build over time. Okay, Latasha, I think we're going to need to hear more from you. Going through these questions, there were a number that were kind of about HUD regulations. And back to the slide you had about the legal landscape and the history of some of these housing acts and how they've had this chilling effect on public housing authorities accepting people who use drugs or even entertaining them as residents if they associate with people who use drugs. I think there's still a lot of misinterpretation and misunderstanding of those legalities. And that is one of the reasons why HUD and HHS came out with the Biden letter saying, like, don't worry about it. Naloxone, you should still do. But let me summarize these questions here. An audience member asked, how do you navigate HUD regulations? And can you share a bit more about how you got buy-in from the Housing Authority and how you navigated HUD's alcohol, drugs, and criminal activity restrictions? Fear of liability and HUD guidelines are currently stalling my organization's harm reduction efforts. And last, any suggestions on how to overcome the HUD barrier of not allowing any harm reduction supplies since residents are not contracted to use drugs? Even within the questions, it's all mixed up. Yeah.
Yeah, and I was going through the chat and typing some responses, but I think it's appropriate to address the group openly first. HUD does not prohibit us from having harm reduction supplies on site. And actually, residents being in possession of harm reduction supplies is not evidence, right, that they are violating the policy or doing something that's impermissible. So I do want to say that HUD did issue a notice in partnership with HHS that clarifies this so that all of your PHAs can know that this is acceptable. This does not run afoul of the federal laws that we talked about earlier. And a lot of them will be anxious about some of those things. And that's okay, because now we have official guidance, we have notice documents, and we have FAQs that say, this is acceptable and this is how you do it well. In fact, last week, our program was able to participate in a HUD webinar to over 350 participants from your local housing authorities across the nation, where we talked about why this is important, how you can do this to really make sure that we're prioritizing resident well-being. We talked about the Fair Housing Act and how some of those considerations may come into play in ways that public housing authorities can actually move forward. So if you are having challenges communicating with the leadership at your housing authorities, I would encourage you to pull those resources down when you go to engage with them, when you go to have conversations with them. Find that recording from the webinar that took place last week. It's on HUD Exchange, right? Direct them to that. There is a lot of information that's available now that was not available when we went through this process with our partners at Center. When we went through our process, we were responding to an emergency and trying to make sure that people were safe, right? But you all are in a slightly different landscape. There's a lot of guidance that says you can do this, and in fact, you should do this. And so I would stick with those documents. Your housing authorities are going to trust that guidance, and they're going to be more inclined to find that persuasive than anything else you might mention.
Boom. DeAnthony, you had a question you wanted to answer.
Yeah. So there's a question that asked, how can us organizations that provide harm reduction supplies, education, and service better support your efforts? Can we do some of the behind the scenes work to take the burden off you all or other CHWs? So one thing that has helped us with this type of work is a line of communication. A line of communication with community organizations, with respite housing, transitional housing, stuff like that. I believe that line of communication actually helps us stay connected and helps us plan events or anything like that so that when we are planning something for that month, they can come in and do their thing. Because we don't want to leave any community organization out, because they are as powerful as us, and we can't provide a lot of things that they can provide. So, Corey, to answer your question, there you go. Corey was one of the persons that started at the T and helped me, and he's now over at Mo Network. So.
While we're waiting for others to jump in, I've seen a number of questions addressing the mouth-to-mouth guidance that I gave a few minutes ago. People are concerned about fentanyl and essentially like having accidental contact with fentanyl from doing mouth-to-mouth. I am not aware of any cases where that has ever happened and led to intoxication, let alone death. Guidance from the World Health Organization, the CDC, every big body and harm reduction entity would say, don't worry about passive fentanyl exposure. That is a big myth that has also been propagated a lot over the last few years. You cannot overdose or even absorb fentanyl from touching it, from being around it. There would have to be so much actual powder fentanyl like sitting on someone's lips for you to have any chance of absorbing it through mouth to mouth. So I understand the fear because, fentanyl is intense and there's reasons to be humble about the growing presence of fentanyl, but there's also a lot of moral panic and disinformation around fentanyl exposure. So don't be a victim of that. Okay. Me again. Oh boy. Okay. What has been helpful in linking all these organizations of all types, particularly in keeping the voices of impacted community members centralized across so many organizations?
Can you repeat that for Hannah?
Yes. Yeah. For Hannah. Clever. What has been helpful in linking all these organizations of all types, particularly in keeping the voices of impacted community members centralized across so many organizations? Would love to hear from D'Anthony and Hannah, maybe Dajay.
So I think it comes down to, we had relationship building with the housing authority and the property managers, and the relationship building with the residents. It's the same way for your community organizations. And it's really all about, who you know, and then taking that when you're talking with residents and, if they say certain things or key things that stick out, then you can, go back to your resource list that has all of your organizations and go back and get in contact with them to have them come out. And that way, kind of like we talked about earlier, we're not addressing the needs that we think that they have. We're addressing the needs that they tell us that they have.
We've also gotten a lot of questions. Well, actually, let me just back up and add a bit. I think there really was some serendipity here for us in St. Louis. The fact that we had Center established as an initiative, a year and a half before the mass overdose event was incredibly helpful because we were able to spring into action because we were already all talking to each other and working broadly as a collective on various efforts and having weekly or biweekly meetings or touch points or, going on outreach together, this or that. So this just became our priority, for a series of months. And the only missing ingredient was the housing authority because they were not part of our little group at the time. And so, as Dajay mentioned, like, yeah, it took us a freaking year to get into the housing authority. So we're not saying that's easy. And shout out to Alana Green, if she's on here, who is a director who I think maybe saw one of our tweets. Like, I don't think it had even risen up to her level. Yeah, she didn't even know that we were trying to get a hold of her agency. So, in terms of like the linkage and collaboration, ideally, you'd start that now if you haven't already, so that you are poised to be in a place to respond when critical incidents pop up. Because it's really hard in the wake of a community tragedy to get everything together that you might need to even begin building partnerships. Okay, a number of people essentially asked versions of the questions of like, where do we start? We want to start this locally, but we kind of don't know where. And I imagine those of you who submitted those questions are coming from one perspective. You're a community health worker, or you're a substance use treatment provider, or you're a property manager. So I'd love for the team to jump into this one. But first, I would say, look at the ingredients that you have. Back to our ingredients slide. You need naloxone, a steady supply. You need the ability to train property managers. So you need the housing authority on board. You need CHWs or peers or volunteers who can do the ground game. And you need to be able to connect people to other resources in addition to just naloxone. So if I were you, I'd lay out those 4 ingredients and be like, okay, where am I strong and where am I weak? And focus on building up your weak points to make sure you have all the ingredients for the recipe. What am I missing though, team?
No, for sure. You nailed that. And then I see there is a message here in the chat that is talking about where a person could reach out to get the information for emergency responses and that sort of thing, fentanyl. And so it's talking about the fentanyl here. And so it's going to be very easy to get that information because people have studied and done the work, and you will be able to access it through the different forms of the different agencies that supported this right here on this training. You will definitely be able to get as much information as you want or need. And as Rachel said, you don't want to miss the piece of connecting with others, because some of those questions you have, someone else has them, and people are already getting started. And so they can help you. So you don't have to start from scratch. Even though it is scratch, you could end up in a much better position just by collaborating with others.
Yeah, and I wanted to kind of circle back to the question. Could you remind me? I'm sorry, I'm trying to scroll. There's so many questions. I'm trying to.
Sure. I mean, essentially, Daja, can you speak to someone's question who asked, like, how do you keep people who have lived experience with drug use and addiction at the core of this? If you could speak to that in our final minute, that'd be a great way to close.
I like to say that the Center Initiative has a community advisory board that is filled with people with lived experience, continuing to involve people with lived experience, rather that be peers, volunteers, or people who have lived experience as community health workers, has made this process incredibly easy with building trust, because it's such a relatable thing to them, and they're able to communicate things that a lot of people who have not walked in those shoes aren't able to. So hopefully that answers your question. Sorry, I was a little taken by that one.
Okay. That was so fantastic. I don't even want to stop the Q&A. This has been so wonderful. Great questions, great comments. To those who submitted the comments just saying yes to all this, don't worry, we will get all of those to the panelists. But I also just wanted to echo it. This has been just a really engaging, I can't believe it's been an hour and a half just listening to your experience and sharing it with the country. I know that there are so many communities struggling with this very thing. And so what I am left with is just a real message of hope that this is possible. Great work, great partnerships are possible. And that there's just so much hope and compassion that I am being left with. So I just wanted to huge thanks on behalf of HHRC to all of our panelists and to everybody participating today. We'll at least drop the evaluation link in the chat one more time. If it doesn't work the first time, give it another few minutes. But again, thank you all so much, and we will see you next time.